Thank you so much, and thank you for being here and preparing this lecture for us. We really appreciate it.
Quite welcome. Quite welcome. So this afternoon, I'm going to be speaking about plasma cell disorders. And the learning objectives are to discuss the clinical and laboratory assessment of patients with plasma cell disorders, to discuss staging and prognostication, and then end up speaking about therapy. So these are the large groups of plasma cell disorders. We'll spend the first part of the talk discussing multiple myeloma, smoldering myeloma, and solitary plasmacytoma. Then we'll spend some time on monoclonal gammopathy of undetermined or uncertain significance, and monoclonal gammopathy of certain significance. Finish up with some words about amyloidosis, B-cell lymphomas, and Waldenstrom macroglobulinemia. I'm going to start with a patient case. A 55-year-old male was referred because of the finding of a monoclonal gammopathy. So he had an SPEP done, which showed an elevated gamma globulin and an M spike of 1.19 grams per deciliter. On quantitative immunoglobulins, his IgA was elevated at 1606 with a range of 70 to 400 normally. And serum immunofixation revealed an IgA lambda monoclonal protein. The serum-free lambda was measured at 112 with a range of 5.71 to 26.30. And the serum-free kappa was 9.66. The serum kappa lambda ratio was depressed at 0.09 with a normal range of 0.26 to 1.65. Urine studies were obtained, but did not show any proteinuria or monoclonal protein. Patient's complete blood count, creatinine, and calcium levels were all normal. So think about this case as we go through the talk, and we will hopefully come to a consensus as to what's going on with this patient. There is something called clonal evolution in patients with myeloma. There are normal numbers of plasma cells in the body ordinarily. Mgus, which is monoclonal gammopathy of undetermined significance, are patients with a low number of monoclonal B cells, plasma cells, excuse me, of less than 10% in the bone marrow. Smoldering myeloma patients have more than 10% monoclonal plasma cells in the bone marrow. And then we come to multiple myeloma and even plasma cell leukemia, where you have circulating monoclonal plasma cells. So to start with multiple myeloma, the incidence in the US in 2020 was 32,270 cases, and there were 12,830 deaths. It's more common in African Americans, and the statistics show that it's twice as common as in other populations. There are a number of known risk factors, including radiation exposure, chemical exposure, such as to benzene, Agent Orange for people who were perhaps Vietnam veterans, people who were exposed to toxins at the World Trade Center on 9/11. Male gender seems to be a risk factor, and there may be some hereditary predisposition to multiple myeloma. So the definition of multiple myeloma requires a monoclonal protein in the serum or urine, except for those rare cases who have non-secretory myeloma. Just to point out that patients with light chain myeloma don't have an intact immunoglobulin protein, and may just have light chains in the urine and or the serum. And monoclonal bone marrow plasma cells greater than 10% or a biopsy proven bony or extramedullary plasmacytoma, plus any one or more of the myeloma defining factors. And this is going to be important as we go through the other types of plasma cell disorders. Hypercalcemia, renal insufficiency, anemia, and one or more osteolytic bone lesions on plain X-ray, CT scan, or PET scan. Clonal bone marrow plasma cells greater than or equal to 60%, and involved, uninvolved serum free light chain ratios greater than 100, or greater than one focal lesion on MRI studies greater than or equal to 5 millimeters. So you need all these criteria to make a diagnosis of multiple myeloma. So how do we work up these patients? First of all, a history and physical exam is important, of course, for bone pain or any bony tenderness. Complete blood count, differential platelet count, and RBC indices. A high MCV, which has a number of different causes, of course, may be a tip-off to the presence of a monoclonal protein in the peripheral blood. On the peripheral blood smear, you may see rouleau formation, Mott cells, or even sometimes plasma cells. You're going to want to check patients' renal function, liver function, albumin, calcium, of course, as I mentioned, serum uric acid and LDH, and beta-2 microglobulin. And the latter two are important for staging, and we'll come to that in a couple more slides. Creatinine clearance may be important to assist you in determining the patient's renal function or dysfunction. Then we come to serum protein electrophoresis, serum quantitative immunoglobulins, and serum immunofixation. The serum free light chain assay has come into much wider use in the last couple of years, and it's highly sensitive, and it's useful if there's no measurable M protein, and it's important to look at the degree of the free light chain elevation. 24-hour urine for total protein, for urine protein electrophoresis, and urine immunofixation is also part of the workup. As far as looking at bone lesions, which is part of the diagnostic workup for myeloma patients, we prefer whole body low dose CT scan or PET scan. The PET CT may miss lesions seen on the whole body CT scan, but is very good for extramedullary disease. Since these patients may have renal dysfunction or tendency towards renal dysfunction if they have light chains, we like to avoid contrast unless it's absolutely necessary, but a skeletal survey, which has been done in the past, is really no longer the standard of care for confirmed myeloma patients, although it may be useful in patients who have what we think is just Mgus. Nuclear bone scans not useful in myeloma patients because nuclear bone scans, as you know, pick up lytic lesion, blastic lesions, excuse me, and the bone lesions in myeloma tend to be purely lytic. So unilateral bone marrow biopsy and aspirate should be done. This would include immunohistochemistry and or flow cytometry. And cytogenetics are important because FISH panels can give you an indication of whether the patient has any adverse markers, any adverse prognostic markers in the bone marrow. Hepatitis B and hepatitis C and HIV screening is important, and HLA typing may be useful in certain cases. This is a picture of a peripheral blood smear with a plasma cell in the top box, and in the bottom box, a Mott cell, which has a conglomeration of immunoglobulin in the cytoplasm. The top slide shows you the characteristics of a plasma cell with an eccentric nucleus and a perinuclear clear zone. Pretty typical for plasma cells. This is a picture of a bone marrow. It's pretty heavily infiltrated with plasma cells, which I think if you can use your imagination, you can see some here and here. Sorry, I couldn't get it a little bit higher power, but this is supposed to be an example of a typical bone marrow in a patient with myeloma. This is actually what I think is a beautiful picture of infiltration of plasma cells in a bone marrow. These are all, with the exception of a couple myeloid cells, this bone marrow is almost completely infiltrated with plasma cells. As far as bone lesions go, you can see on this plain X-ray some lytic bone lesions in this patient's skull here and here. And then more impressive, I think, is this MRI of a patient's vertebral column with a lot of lytic bone lesions. And again, you can see lytic bone lesions and vertebral collapse in a patient like this. So how do we stage patients with myeloma? It's interesting because the staging system, neither the original staging system nor the revised staging system do not include anything about the height of the immunoglobulins or the type of immunoglobulins. So the original international staging system relies on the patient's serum beta-2 microglobulin and serum albumin. So patients with low beta-2 and normal serum albumin are in stage 1. Patients who have a high beta-2 microglobulin are stage 3, and stage 2 patients are in between, neither stage 1 nor stage 3. The revised system also looks at the serum LDH, which is important. If it's low, patient is stage 1, and if it's high, patient is stage 3, and also looks at chromosomal abnormalities by FISH or by cytogenetics. So I'll turn now to some discussion of how we treat these patients. Patients usually get 4 cycles of induction chemotherapy, and we tend to use drugs of different classes for these patients. So proteasome inhibitors such as bortezomib, plus IMiDs or immunomodulatory agents such as lenalidomide, plus steroids, and in many cases these days, monoclonal antibodies against CD38 such as daratumumab. The preferred 3-drug regimen in 2021 is RBD, which is a combination of lenalidomide, bortezomib, and dexamethasone. And the response rate is quite high, overall responses. And 74% of patients attain what's called a very good partial remission. The regimen called CyBorD or VCD, which is cyclophosphamide, bortezomib, and dexamethasone, is most useful for patients with renal insufficiency. We tend not to want to use lenalidomide in patients with renal insufficiency, so cyclophosphamide is substituted. You have to be careful about cyclophosphamide because it's an alkylating agent, so its use should be, or its time should be limited because of possible bone marrow suppression that's long lasting and may be a problem in a transplant eligible patient. Some patients who present with acute renal failure and have multiple myeloma have been treated with plasma exchange in the past to try to lower the circulating immunoglobulin. It's probably not that useful, and it's controversial if you look at the literature. In 2021, there's much more use of 4-drug regimens. So adding daratumumab or carfilzomib to patients, especially who are high-risk patients, is now becoming the standard of care. Certainly, it's more efficacious and is best for people who are high risk and have negative prognostic parameters. So patients who are eligible for transplant usually undergo stem cell harvest during induction therapy. They're often referred for transplant consideration after their 3rd or 4th cycle of chemotherapy. Those patients have their induction chemotherapy stopped for the stem cell harvest, and then they usually get 1 or 2 more cycles after that and go on to transplant, which is high-dose chemotherapy and autologous stem cell transplant. Allo transplants are not favored upfront in myeloma patients these days because there's a very high treatment-related mortality and a lot of graft versus host disease in those patients. So patients after transplant are put on maintenance therapy, and this is usually single-agent lenalidomide or single-agent bortezomib. There's also a newer drug called ixazomib, which is used in some circumstances. And questions still being looked at include whether high-risk patients need 2 drugs instead of 1. And does maintenance help even if patient is not in minimal residual disease negativity state? A lot of our patients are not transplant eligible, either because of advanced age or because of multiple comorbidities. So these patients are treated a little bit differently. They do get induction chemotherapy. They may get 2 or 3 drug regimens instead of 4. Some commonly used regimens are lenalidomide plus low-dose dexamethasone, or something called VRD light, which is VRD at lower dose levels, and daratumumab and RD, or Kyprolis, which is carfilzomib, and RD are often used. So these patients are treated until they, assuming they respond, are treated until they have progressive disease or they're intolerant of the treatment that they're getting. And if patients do well, they can be put on a maintenance regimen just like the post-transplant patients would be. There are a lot of additional therapy considerations in myeloma patients, and I'll try to go through them quickly. One is that radiation therapy is used for palliative reasons, but it is bone marrow, it's got some bone marrow suppression activity, so you try to limit the field size, especially in patients who may be candidates for stem cell harvest. Bone disease is a problem in myeloma patients, and most patients will be getting a bisphosphonate or denosumab as long as they can get dental clearance ahead of time to ward off the possibility of getting osteonecrosis of the jaw. Orthopedic surgery for impending or actual pathologic fractures, especially in weight-bearing bone, is not uncommonly done. And neurospine surgery is used for patients who need vertebroplasty or kyphoplasty because they have an unstable spine or cord compression that's deemed surgically appropriate. Hypercalcemia is often seen at presentation, and patients are treated with hydration and zoledronic acid or denosumab, steroids, pretty typical hypercalcemia treatments with which you're all familiar, I'm sure. Renal insufficiency is a problem in a lot of the myeloma patients, and it may affect the regimen choice and may affect your dose modifications. Certain patients with myeloma are at risk for thrombosis, especially the patients who are on an immunomodulatory drug such as lenalidomide, and those patients are uniformly treated with aspirin unless they're anticoagulated for another reason. They can be given recombinant erythropoietin for anemia if necessary, and then of course pain management. IVIG is being studied for myeloma patients who are at high risk or have a history of frequent infections, and they should get their standard immunizations, which actually have to be repeated after a year in the post-transplant patients. Anti-infective prophylaxis is important. These patients are immunocompromised both by their disease and by their lack of functioning plasma cell activity. Patients who you think are going to be receiving high-dose steroids should be on PJP prophylaxis. They should get prophylaxis against herpes zoster, and then fungal prophylaxis and hepatitis B prophylaxis in the patients who are core antibody positive should be considered. There is a school of thought that 3 months of antibacterial antibiotic at the time of diagnosis when first beginning chemotherapy is useful in these patients because it seems to be a time when they are most at risk for bacterial infections. I'm going to go through this quickly because it's kind of a research tool, but patients who have the best response to treatment and develop what's called a stringent complete response are those patients who have a clinical complete remission, normal protein studies, normal free light chain ratio, and absence of clonal plasma cells in the bone marrow by all studies, immunohistochemistry and immunofluorescence. And those are patients with what we call minimal residual disease. A complete response is patients who have less than 5% plasma cells in the bone marrow. And what we see most often, because outside of a research study, patients don't always get repeat bone marrows. A very good partial response are those patients whose serum and or urine M protein is detectable by immunofixation, but no longer by serum protein electrophoresis. And patients may be classified as a partial response if they have more than a 50% reduction in their serum M protein. Patients who have no change or stable disease don't meet criteria for any of the previous categories that I mentioned. And there are criteria, at least in the research setting, but also in clinical care as well, for what constitutes progressive disease or relapse disease. So what do we do with the relapsed or refractory myeloma patient? Well, it would make sense to give regimens with a drug class not previously used. I mean, if the patient only got a 3-drug regimen, you could add a 4th drug of a totally different class. But these days it's difficult because many patients are getting a 4-drug regimen up front. So new drug classes are in development. There's an oral nuclear transport protein inhibitor called selinexor, which has become popular. And then there's humanized anti-BCMA antibody drug conjugate that's available. CAR T-cell therapy is in use and being studied in patients with myeloma. And then there are also investigational agents coming down the road. So the overall median survival of myeloma patients in 2020 was estimated as 6 years. The transplant eligible patients do best. They have an overall survival of 80%, and elderly patients greater than 75 years of age have a median overall survival that's lower, approximately 5 years, and there certainly are deaths due to comorbidities in these patients. Whether these figures will improve with new therapies is hoped for, of course. And there's a kind of a new concept called operational cure, in which patients have persistence of a very low level of detectable cancer cells while either on or off treatment, but in what's called a deep disease response. So they have minimal levels of residual disease by the most sophisticated testing, but remaining in remission clinically and symptom-free over the long term. So you may start reading about operational cure in myeloma and other malignancies. Just going to say a little bit about solitary plasmacytomas because we do occasionally see this. There are 2 classes. One is solitary plasmacytoma of bone, and the other is extraosseous, which are plasmacytomas in the head and neck and the upper respiratory tract. So these patients do have a risk of progression to myeloma. It's higher in the patients with bone plasmacytomas than in the extraosseous. The workup for these patients, because this diagnosis is usually made on a biopsy, is to do a bone marrow biopsy to rule out multiple myeloma. Patients, by definition, can't have any Krabs criteria, so they can't have hypercalcemia, renal insufficiency, anemia, and any other bone lesions. Some of these patients can actually have monoclonal proteins in their serum or urine. And the significance is that if they're treated with radiation therapy, which is the primary treatment, the monoclonal protein should disappear. And if the monoclonal protein reappears, then you have to be concerned that the patient actually has progressed to myeloma, which does happen. These patients generally do pretty well. They need to have yearly imaging of whatever area was originally involved for 5 years before they can be considered cured. So let's go back to our patient case for a minute. The patient did have a bone marrow biopsy. It was hypercellular for his age, had trilineage, hematopoiesis, and full maturation. And there was a lambda-restricted monotypic plasma cell infiltrate seen diffusely and comprising 40% of overall cellularity in the biopsy. And it was read as consistent with plasma cell myeloma. The immunoperoxidase stains were positive for CD138, CD38, and CD56, as well as lambda. And FISH studies showed a deletion of 13q and a translocation of 1114. So as we go through the next couple of slides, I'd like you to think about whether you agree with, not with the histologic, cytologic reading, because that's for the pathologist to do, but whether you agree with this patient that this patient has plasma cell myeloma or not. So this is a schematic of myeloma, smoldering myeloma, and monoclonal gammopathy of undetermined significance. We already said that the myeloma patients characteristically have an M protein in the serum or urine. they have clonal plasma cells in their bone marrows, and they have the presence of end organ damage. Now, our patient on the previous slide had bone marrow plasma cells of 40%, but no end organ damage. There are, of course, patients who have what's called Mgus with a low M protein level and a low percentage of bone marrow plasma cells. Again, have no end organ damage either. So let's talk a little bit about smoldering myeloma, because I would argue that that's what this patient has, despite the fact that the pathologist wrote that the patient's bone marrow was consistent with plasma cell myeloma. We don't have to agree with that because, well, we make a clinical diagnosis. So smoldering myeloma patients are asymptomatic and have no CRAB criteria. So I would argue that our patient is asymptomatic, has no CRAB criteria. Their serum monoclonal protein may be greater than 3 grams per deciliter, or they may have Bence-Jones protein more than 500 milligrams for 24 hours, or they may have clonal bone marrow plasma cells of 10 to 59%. So I would argue that that's where this patient lies, because this patient had bone marrow plasma cells of 40%. The patient cannot have any myeloma defining events, cannot have amyloidosis. So I think that fits perfectly with our patient. No CRAB criteria, no bone lesions. We assume that bone lesions have been looked for and were negative, and had an increased number of plasma cells, but not meeting the criteria of 60%, which would give you a diagnosis of myeloma. Now, these patients do progress to myeloma, although some people do well over time. If the skeletal survey, if that's been done, is negative, then you would assess for bony disease with a more sophisticated, more sensitive study, such as whole body MRI or a PET scan. The patients who have high risk for progression from smoldering myeloma to multiple myeloma are those with free light chain ratios greater than 20 and greater than 20% plasma cells in the bone marrow. So our patient probably is high risk for progression to myeloma. High risk cytogenetics are also a risk factor. And clinical trials are underway to see whether there's any benefit in treating smoldering myeloma patients to prevent them from progressing to myeloma. And there does seem to be some benefit in the high risk patients. And there are different risks of progression estimates, such as the one that comes out of the Mayo Clinic, which talks about the percentage of bone marrow plasma cells, the M protein level, the adverse cytogenetics, as I mentioned. So low risk patients in the Mayo Clinic studies did not have any measurable time to progression, although the high risk patients were estimated to have an average risk of progression to myeloma of only 14 months, with the intermediate risk patients in between. So here's another chart of suspected monoclonal gammopathies. We mentioned that patients who have monoclonal protein bands on SPEP, immunofixation, high serum free light chain ratio are the patients who are going to be diagnosed with myeloma when you finish your workup. Patients who have a monoclonal protein band on serum studies and a normal serum free light chain ratio and kappa lambda ratio may have Mgus or B-cell lymphoma, CLL, or Waldenstrom's, and we will talk about that a little bit later. Patients with hypogamma-globulinemia should be looked at carefully, because even though they may have a normal SPEP and serum immunofixation, if they have an abnormally high serum free light chain ratio and the kappa lambda, serum free light chains and the kappa lambda ratio is altered, they may have light chain myeloma or something called light chain deposition disease or primary amyloidosis. So what about Mgus, monoclonal gammopathy of uncertain or undetermined significance? We see this a fair amount in hematology, and the incidence is certainly there as the population gets older. The incidence is 120 per 100,000 in males in their 50s or at the age of 50, but rises to 230 per 100,000 at age 80 in males. For reasons that we don't quite understand, the incidence is lower in females, but then again, all B cell malignancies seem to be more common in males than in females. Mgus is most often IgG. It's less often IgA. And in fact, if you have a patient with an IgA monoclonal protein, you should think long and hard before giving them a diagnosis of Mgus, because it's just less likely you're only going to find Mgus. And if you do the bone marrow, you may be surprised and you find that you have a lot of plasma cells in the bone marrow. You may actually have a patient with smoldering myeloma rather than Mgus. So how are we sure that the patient has Mgus? Patient can't have any CRAB criteria. A bone marrow biopsy, when done, is going to show less than 10% plasma cells. But in practice, these patients, if they meet the other criteria for Mgus, unless with the possible exception of the IgA patients, don't usually come to bone marrow biopsy. The M protein level has got to be less than 3 grams per deciliter, and the low risk Mgus patients have M proteins of less than 1.5 grams per deciliter. They should have a normal free light chain ratio, and the urine M protein should be less than 500 milligrams per day. Now, having said that, we do see patients who have polyclonal hypergamma-globulinemia or CKD, who often have elevated kappa and lambda free light chains both due to increased production or reduced physiologic clearance, but the kappa lambda ratio is usually normal or only slightly increased. So what happens to these patients? Well, the IgG and the IgA Mgus patients may progress to myeloma, to B-cell lymphomas, or to amyloidosis. The IgM Mgus patients, when they progress, are likely to progress to Waldenstrom's or another B-cell lymphoma. The median age for patients with Mgus is 70. There is an increased risk in first-degree relatives, and you might consider screening a patient if he or she says they have 2 or more first-degree relatives with myeloma. Increased risk of progression in males and in immunocompromised patients and those who've had occupational exposures. And they seem to have a shorter survival than controls of matched age and sex. The development of myeloma, lymphoma, and amyloidosis, and what we tell patients, is approximately 1% per year. Although there are some higher risk patients, patients with a higher M protein level, patients with IgA or IgM paraproteins, and abnormal serum free light chain ratios, as I mentioned before. There are some clinical trials going on to see what, if anything, can be done to improve the prognosis in patients with high risk Mgus. There's a relatively new term that you may read about, which is called monoclonal gammopathy of certain or of clinical significance. And monoclonal gammopathy of renal significance is, I think, the most commonly written about. These are patients with monoclonal protein in the serum or the urine who have prominent kidney involvement, but don't meet criteria for multiple myeloma. The diagnosis requires a kidney biopsy, and most often the patients are sent to hematology first to make sure they don't have myeloma. But kidney biopsy, which can show multiple histologic subtypes, does show deposition of IgA, IgG, or free light chains in the kidney biopsy. So patients who have IgG, IgA, or just free light chain MGRS are treated as if they have myeloma. Patients with IgM MGRS are treated as Waldenstrom's patients are treated. And MGRS with monoclonal B-cell lymphocytosis only is treated as CLL. There is also an IgM monoclonal gammopathy of neurologic significance, and these are patients with anti-MAG antibodies, and they are treated with rituximab. There's also an entity called POEMS, which you may have heard of, polyneuropathy, organomegaly, monoclonal protein and skin changes, and an entity called TEMPI, which is telangiectasias, elevated erythropoietin with erythrocytosis, and a monoclonal gammopathy, along with perinephric fluid collections and intrapulmonary shunting. And the last of these etiologies is called Schnitzeler syndrome, which is characterized by chronic urticaria and an IgM monoclonal gammopathy. Just going to say a few words about amyloidosis. I mean, it's interesting because amyloidosis and multiple myeloma share a common causal root with clonal malignant plasma cells in the bone marrow. But unlike myeloma, the clonal plasma cells in amyloidosis do not accumulate and cause bone lesions and renal insufficiency, et cetera, but induce the deposition of light chains in various organs as amyloid fibrils. So light chain deposition is most problematic in cardiac and renal and liver tissues. The diagnosis can be made in a couple of different ways. Bone marrows in these patients show plasma cell infiltration plus Congo red stain. You can also biopsy a fat pad or do rectal biopsy, or of course, biopsy of a myocardium or liver or tissue, or kidney or liver tissues. So these patients are treated similar to myeloma patients with bortezomib-based therapies usually, and are often referred for transplant. As far as the B-cell lymphomas go, it's a surprising number of patients with B-cell lymphomas have monoclonal gammopathies associated. So the follicular, mantle cell, marginal zone, low-grade lymphomas have a 25% incidence of monoclonal gammopathy. And it's actually a predictor of poor outcome in these patients, and it's often an IgM monoclonal protein. So CLL, or small lymphocytic lymphoma, 10% of those patients have monoclonal proteins detected, and they may be either IgG or IgM. And they're said to have a shorter treatment-free survival, but not a difference in overall survival. Patients with diffuse large B-cell lymphoma may have monoclonal gammopathies, and these are known adverse prognostic indicators in those patients, particularly in patients with extranodal DLBCL. And these monoclonal gammopathies are usually IgG. Going to finish up talking about Waldenstrom's macroglobulinemia. Strictly speaking, it's not considered a plasma cell disorder because it's actually clinically more like a lymphoma, but it's characterized always by an IgM monoclonal protein. The bone marrow in these patients shows a lymphoplasmacytic infiltration, which is CD19 positive, CD20 positive, surface immunoglobulin M positive, CD5, CD10, and CD23 positive, similar to your B-cell lymphomas. There's something called the Nyd mutation, which is characteristic and is seen in the vast majority of patients with Waldenstrom's. In those patients, the BTK inhibitors are the drugs of choice. Some of the patients have a CXCR4 mutation, and these patients are less responsive to standard treatment. As I mentioned, these patients behave more or present more like patients with lymphoma. They have lymphadenopathy, they have hepatosplenomegaly, they may have anemia, but they usually do not have bone lesions, and renal involvement or hypercalcemia is quite unusual. The Waldenstrom's patients may present with hyperviscosity. IgM is a very large protein, and patients may have bruising, bleeding, anemia out of proportion to the actual hemoglobin, hematocrit, and red cell count, and headaches and visual changes. So these patients are treated with plasmapheresis. And plasmapheresis is also useful for patients who have very high IgM levels, such as greater than 4,000 prior to initiation of treatment with rituximab or ofatumumab or carfilzomib, because in those patients, the IgM level may rise when you initiate therapy. This is an example of a bone marrow of a patient with Waldenstrom's. As you can see, most of these cells are look like small lymphocytes, but there are plasma cells here and here admixed among the lymphocytes. So this is a pretty characteristic bone marrow picture in patients with Waldenstrom's. There is a scoring system for patients with Waldenstrom's, and it's a little bit different than the myeloma scoring system. It does take into account age, does also take into account the LDH and serum albumin, and this should be microglobulin, not macroglobulin. And just a few references that you might want to take a look at sometime if you're interested in the plasma cell dyscrasias. And be happy to take any questions in the couple of minutes that are left.
Thank you so much, Dr. Hawkins. So yes, if anyone has any questions, feel free to just unmute yourselves or just write it in the chat.
Why is IgA less likely to be Mgus?
I think it's because IgA is more likely to be myeloma. So it's kind of it's a statistical finding.
Okay, it's not like physiological, like more aggressive or anything like that. It's just
not that I know of. Certainly IgG is the vast majority of Mgus patients. I think with an IgA patient, you need to be on the lookout to look carefully and make sure that they really don't have myeloma or smoldering myeloma, because remember, the smoldering myeloma patients don't have any CRAB criteria, so they may just present with a monoclonal IgA. And you wouldn't know that they have smoldering myeloma until you do the bone marrow, because it's really based on the percentage of plasma cells in the bone marrow.
great. Thank you.
Anyone have any other questions? Okay, so I think that's it. Thank you so much, Dr. Hawkins, for your time and for setting this presentation up for us and coming here today. We really appreciate it.
Quite welcome.